having spoken about about uh, epidemiology, let's talk about pathogenesis, because that explains the differences between the genders, the ethnic groups, etc., etc. So, pathogenesis deals with the etiology and progression of a disease in an individual rather than a population. And the famous example is, we talked about cholera. John Snow traced it to that well. Well, Passini described the bacillus itself. He identified the Vibrio cholera in 1854, but so he discovered the etiology, the pathogen itself. But then in India, Sambhunath D discovered the enterotoxin that is secreted by the cholera that causes the diarrhea, and that was in 1959. So we want to look at obesity of what we think is happening. We think that we have signals from the GI tract, and for example, for the signals, we have the ghrelin. When the stomach is empty, it tells you that there's increased hunger. We have GLP-1 for satiety, that comes from the small intestine. These controls are sent to centers in the mesolimbic system or the hypothalamus, part of our brain, the addiction center, or we call it the centers for pleasure as well, where which is associated with food. So we usually eat for pleasure. So those centers So let's look at the pathogenesis of obesity. So basically, we have signals that come from the GI tract. So the stomach, when it's empty, you have the release of the hormone ghrelin, which is what is removed during a sleep gastrectomy. And also you have the satiety feeling that comes from the food, releasing the GLP-1 incretin or hormone. So that hormone would have an effect on the subcortical and hypothalamic level, which is what we call the centers for addiction, centers for eating, centers for hunger. They're all in the hypothalamic region, so they're not within your control. They're related to your emotional centers. And that is where the new medications work as GLP-1 agonists. So in those centers, you have what we call the pleasure of eating, because when you eat, you release dopamine, so you feel happy, you feel thrilled, you feel full, and also seeking that release of dopamine is the motivation for us to eat. The receptors, like the opioids and the cannabinoid receptors, they're stimulated by having, for example, chocolate. Those are also stimulated. So food is somehow related to addiction in a sense that it affects the same centers in the hypothalamus that are affected by drugs. And the cortical level is where the executive function. That is when we decide whether we will comply with our subcortical stimuli that came to our brain, or the peripheral stimuli, whether it's ghrelin or whatever, comes to our brain, and then we make a decision to respond and eat, or we don't think it's the right time and we decide, okay, I'll abstain from foods. For example, if you're fasting in Ramadan, for example, if you're a Muslim. So this is how the control of eating for a human being. Now, we have what is called a set point theory. What is a set point theory? That you always have a set point that is predetermined, or we call a set fat mass. So the way it happens is that whenever you have an energy gap, so your desire is to go for weight loss, so you're abstaining from food, so there is an energy gap. You don't have enough energy to sustain your daily living. For example, a male would need 27 calories per kilogram per day. A female would need 25 calories per kilogram per day. So that is the minimum to sustain living. So when that happens, when you have a deficiency in calories, there is what is called metabolic adaptation. It's a survival mechanism to protect you. So what happens? You have the satiety hormones diminish, such as GLP-1, such as leptin, POMC, PYY, and all these. And at the same time, when that happens, you have an increase or abundance of the hunger hormones, such as ghrelin. and MPY and the aquathine related peptide. So all these will make you look for calorie-rich food in order to satisfy that deficit. And you couple it with the dopamine, the need for dopamine to be released in the brain. All these will go and stimulate you in your zeal to find food. And then you start eating. So as a result of which, when that happens, then you gain weight. Why? Because your body acclimatizes to the deficiency as well by reducing energy expenditure and increasing what we call the stressful hormones such as cortisol. This is a homeostatic mechanism altogether that aims towards you, stimulating you to have a food-seeking behavior, and then that is when you reduce the energy gap and you gain weight again. So you'll always be going through this circle. You fast, you immediately get all these stimuli from everywhere, asking you to go back to that set point theory. Now, we talked about males and females being different, and the androgen hormones in males and the estrogen in female. What do they do? In fact, the impact is seen obviously when a female gains weight. She gains weight all over her body. It's distributed evenly, more or less. But when a male gains fat, it's mostly within his viscera or mostly within his abdomen, within his torso. So we have two types of fat. We have fat that is underneath the skin, such as in the thighs, and the back, and the arms. This fat is called expandable fat. So it expands easily because it has enough space. And there is the non-expanding central fat. The central fat, and that is the reason why we say there is a metabolic theory. There's metabolic disease from gaining weight in the wrong place. The metabolic theory says there is non-expanding fats, which means if you add to it, so if you have the fat cells inside your viscera, there is limited space for those fat cells to expand. Why? Because they're usually compressed within the mesentery of the small intestine or within the liver, for example. So when you expand them, they explode. And when there is unhealthy expansion, that is when you release mediators, and those mediators are the ones that cause the release of a chronic slow inflammation that results usually in illnesses. And a famous example that was tried, somebody did liposuction. So when you do liposuction, you remove the fat cells with their content of fat from underneath the skin. So if that person gains weight, and that is the experiment that was done by Fabiano Benatti. So he basically removed fat underneath the skin, and so that those people who gained weight gained it in the fat cells that were not removed, and usually they are visceral. So what happened? They developed an illness that they didn't have at the same weight. So their weight didn't change, but their pattern of obesity became central fat, which is inflammatory fat, and hence their LDL increased and cholesterol and fatty acids. Show an example. Here are two patients. One is central obesity and one is all over. The one on the left has a higher BMI, his BMI is 53, and he's not sick. He's metabolically healthy. While the one on the right, his BMI is only 38, but it is within the central fat. He has all the metabolic diseases, diabetes, hypertension, hyperlipidemia, and ischemic heart disease. And to explain it from an X-ray point of view, if you look over here, the CT on the right says systemic fat. So that is the fat that is peripheral underneath the skin. You can see it's underneath the skin, the full arrow, and the small arrow is the visceral fat. You can compare the two. So the one on the left has more visceral fat than peripheral fat. So we expect the one on the left to be sicker than the one on the right. And that is how we look at obesity. You can see the one on the right has central fat, the one on the left has fat all over. So they're not the same. And to explain it further, I'll tell you that we have signals that come from this necrotic fat or from the release of mediators. So when there is a chronic inflammation, you release more insulin because you develop what is called insulin resistance, and the hyperinsulinemia is associated with pigmentation within the skin, which is called acanthosis nigricans, and that is what we see in diabetic before they become diabetic. So acanthosis nigricans is a sign of hyperinsulinemia, insulin resistance, and metabolic disease. And the same picture underneath the skin is coupled with what we see inside the liver. So those are the appearance of the patients underneath their skin. You can see this pigmentation and roughness in the skin. This is from the deposition of melanocytes depositing as a result of the insulin resistance reaction by the body. And the same thing happens within the liver. You can see those livers, 3 livers, are fibrotic. They have, you can see a little bit of fibrosis and inflammation in young people. So those patients who have inflammation, is why does that happen? Because the fat expands within the liver, compresses the bile channels, so bile stagnates within the liver, and the liver is supposed to excrete bile into the intestine to help digest fat, and also it gives the stools its usual color of brownish color. So this bile, when it stagnates inside the liver and doesn't get secreted because of the compression on the ducts, it is an inflammatory substance that results in the liver changing to become fibrotic. And in fact, one of the things that we've noticed is that 30% of patients with obesity would have diabetes. So we're roughly saying about 200 million, but 70% of patients with diabetes and overweight or obesity have what we call MASLD, which is metabolic associated steatosis or steatotic liver disease. So that we have a billion who are suffering from that in the liver. So that brings us to the fact that metabolic disease or metabolic syndrome is all these conditions. If we start from the top left, it can cause depression, mental health, because it plays at the centers in the brain that are related to the pleasure centers, the dopamine centers. Then we have sleep apnea, and sleep apnea relates to the fact that your central system is also restricted, and as well as mechanics of the lung are affected. Then you have the liver disease, which we talked about. Excess fat around the liver causes the damage. And then gallstones, obesity makes people develop gallstones because of the alteration in the absorption of bile, or the ability of bile to remain soluble. And then it also affects the liver. It affects the skin and creates the rashes, or creates what we call acanthosis nigricans. It affects mechanically the joints. Top right, it results in high blood pressure and then risk of stroke. It also increases the risk of heart attacks through all these other diseases such as diabetes, etc. It affects the GI tract by creating the patient to have what you call reflux. Also, it weakens the muscles and the bones and increase the risk of the patient becoming disabled and unable to do usual function, and as a result gains even more weight. Also, the equivalent of metabolic disease or what we call diabetes in female is also infertility. So infertility is caused by the hyperinsulinemia and the complication and lack of ovulation, inability to bear children. It is called PCOS, and today there is a move to change PCOS. PCOS is called polycystic ovary syndrome, and it's a misnomer. It basically talks about a triad of high insulin, unopposed estrogen, increased androgens in a female, and abnormal period, hirsutism. All these together with reduction in good cholesterol creates the metabolic syndrome in females. And obviously, there is an increase in cancer. So, with that said, now we know that the pathogenesis is the reason why all these organs are affected. Some of them are metabolically, some of them are mechanically by the weight, and some of them through release of mediators. Thank you.